Thanks so much to folks that have joined us live here and to the folks who are going to watch this recording later. We've got Cody Clary and Jessica Rankin, docs down at Texas Children's in Austin, who are going to present to us on POCUS and peripheral IV access. I'll let them introduce themselves a little bit more formally, and I'll go ahead and cede the floor.
Thank you, Scott, and appreciate the opportunity to get to come and chat with everybody about something that's of interest to me. And I know Dr. Rankin. I'm a practicing hospitalist at Texas Children's in North Austin, and my interest in POCUS really started in PHM fellowship with a rotation and then a handful of kind of weekend classes. And then I've been very thankful for the mentorship that Dr. Rankin has offered since I've been here as faculty at the North Austin campus because she does some scanning shifts every month, and I've been able to kind of continue my education with her. So as I'm not a POCUS expert at this time, I brought Dr. Rankin and asked her to join me, and she's very thankful that she's able to be here with me today. She's one of our practicing emergency medicine physicians and our POCUS medical director. So thank you, Dr. Rankin.
No problem.
I don't have any disclosures to share with you all today, but I did just want to mention very quickly kind of a medical education disclosure. We're going to be talking about learning a skill that requires our eyes, our hands, when we're talking about POCUS guided IV placement. And through the screen, I think I can convey some knowledge and maybe be able to motivate you to want to learn this skill. But in terms of actually acquiring the skill, it's going to take leaving the session today and going and practicing either in simulation on phantoms or in real encounters with patients. And so I would highly encourage you to take the information that's shared here today and go out and practice it so that you can develop the skill in your bedside practice. We have a couple of objectives that we want to accomplish today. After we finish today's session, we'd like you to be able to identify some basic principles of POCUS, particularly as it applies to peripheral IV placement, and then to also be able to recall proper probe selection and vein identification. And then finally, at the end, being able to outline proper technique for POCUS-guided IV access, knowing that you'll have to take that technique and apply it in real life. Very quickly, I want to start off just with that motivation piece. And the question that always comes to my mind as I'm being asked to learn a new skill is really, is it worth my time? And is it of value to my patients? And I've tried to pull a few articles together here that I think answer that question with a pretty resounding yes. The first article there is a randomized controlled trial that points to POCUS-guided IV placement having a higher overall success rate, though they didn't reach statistical significance in that study. And then these two studies, one being a systematic review, also said that first attempt success rate was higher and that the time to complete the procedure was actually shorter, which we know in pediatric patients is of high value. And then all of these remaining studies are essentially going to say the same thing, that first attempt success rates are higher and it requires fewer pokes, and it's often faster and a more efficient method when we start with ultrasound guidance to get peripheral IV placement. The one thing that I have not mentioned here yet is that there's also some studies that suggest that the lifespan of the peripheral IV when it's done by ultrasound guidance can actually be longer than when it's done by the traditional palpation approach. This is a study that came out more recently in January of this year in JAMA Pediatrics, and it's a randomized controlled trial looking again at first attempt success rates whenever we use ultrasound guidance to place an IV versus the standard palpation technique. And it included 164 children, 93 of those being male, 71 female. All of these were recruited from a single site, Australian Children's Hospital. And the age range probably reflects often what we see and encounter in our own institutions, patients ranging from 10 months to 120 months, which is 10 years, and then the average age being about 2 years old. These patients were divided up between using ultrasound to place the IV from the start and not using ultrasound, just using that standard palpation technique. And they were looking at what is the first time success rate. So the first time I attempt to place that needle, Am I going to get it in the right spot on that first try? And you can see in the bar graph over here, it's a pretty resounding yes in this study too. For the ultrasound guidance group, they had about an 85% success rate for first attempt access. And then in the standard palpation technique, it was about a 33% first attempt success rate. And in this study, it did reach a statistically significant difference. So I hope that literature helps you in terms of answering that question, is it worth my time and a value to my patients? And I think the answer from this that I would take away is that it is.
And then
When it comes,
pretty real quick, just with that study, one of the things I really liked about it was most of these studies are looking at enrolling patients who have either a history of difficult venous access or who are like deemed a hard stick. And this study was just all comers. So even people who you thought you would get easily on a traditional landmark approach. So that's what I really thought was cool about that study.
yeah, absolutely. Thank you for including that. When it comes to deciding if you're going to use the ultrasound machine, often it goes back to what Dr. Rankin was just talking about. For many of our patients, our nurses are going to be the first provider attempting IV access. And so when they come to us and say, we've tried 5 or 6 times and we've been unable to get it, I'd say that's the most common indication that we're being asked to use ultrasound, failed multiple attempts. But then we also have patients coming in that we see frequently as hospitalists, and we know from past experience that they're difficult IV access for some underlying reason, whether that's there's a lot of adipose tissue that makes the palpation technique challenging or something else. But those patients from the get-go were often just jumping to ultrasound guidance to try to prevent having to stick them several times and just getting it from that first attempt using ultrasound. The contraindications aren't really going to be any different than they would be for just that traditional method. I really think about this as anything that stands in between you at the skin surface level and the vein that you're trying to access. Anything that's in there that you wouldn't want to introduce into the patient's system, the blood vessel, you would want to avoid going in that location, or if the underlying vein has been damaged by trauma or burns. So I've listed a couple of practical examples there, including cellulitis, thrombophlebitis, trauma, and burns, but it's really anything in between the skin surface and the vessel. And it doesn't mean that you can't do ultrasound guided PIV placement. It just means that you would want to look in a different location for access. The equipment is also going to be very similar to the traditional palpation technique, with the exception of you're going to be pulling in your ultrasound machine to place it this time. And so we've included that there. And then just as a reminder, knowing at least for myself, I'm often not the provider who's grabbing all of the supplies for peripheral IV placement. There's a tourniquet that you're going to need to try to increase vascular congestion and really plump up those blood vessels. You're going to need some gloves to try to protect yourself from the patient's bodily fluids. And then you're going to, of course, need an IV needle, some tubing and saline that you'll connect up to that needle as soon as you're done with the IV placement. And then a dressing that's going to keep that site clean, with the understanding that these procedures are considered clean and not sterile, but we want to keep it as clean as possible to try to prevent introduction of infection to the patient. And part of that being making sure that we clean the skin really well before we do IV access, usually with an alcohol swab. When it comes to choosing the probe, now that we know we're going to need to do an IV, you're going to want to choose the one that's going to optimize your image for a superficial structure like a vein. And so generally when we're talking about high resolution superficial structures, we're reaching for the high frequency probe, which is going to be somewhere between 5 to 15 megahertz. And that's often going to be your linear probe on the device. When you are attempting to optimize that image further, you can look at what your machine offers in terms of presets. If you have a vascular preset, then it's probably going to make the depth and the gain optimal for imaging superficial structures like veins. But you can also play around with other presets like a musculoskeletal soft tissue, nerve, or superficial preset to see if that provides you a better image than a vascular preset. Now that we know that we need to do an IV and we know which probe to grab, we're going to have to set up that ultrasound to make sure that we keep our device safe and that we're not damaging it during the process and keeping it clean and protecting our patient again from introduction of infection. And so the first step is going to be application of some non-sterile gel to the end of that linear probe. And once you've got the non-sterile gel in place, you're going to cover and protect the probe with some version of a probe cover. I've seen Tegaderms used here. I'm showing just a picture of some sterile gloves that have been grabbed, and it works great as long as you pull it nice and tight and make sure that you've kind of removed all of the air bubbles or excess material from the glove. And then, of course, if you have access to it, you can use an actual sterile probe cover, which would be great if you're doing a procedure where you're wanting it to be fully sterile, but just recalling that for a peripheral IV, it just needs to be clean, not completely sterile. And then for that final part, when you're going to be applying the probe to the patient's skin, you're going to want that gel to actually be sterile, again, to keep this site as clean as you possibly can. Let's talk for a minute about positioning. And when it comes to positioning for any procedure that we're doing, we're going to make sure that we set ourselves up for success and that we're not putting ourselves in a position where we're going to be uncomfortable throughout the procedure. And especially when it comes to venous access, anytime, at least for me, when I'm in a position of discomfort, my back starts hurting, my hands start shaking, and then I'm going to start losing my image from the ultrasound. And so for this particular picture, I would just highly recommend finding a position of comfort, not leaning over, not hurting your back, not causing your hands to shake and making access more difficult. And then making sure that your ultrasound machine itself is within your line of sight. And so for this individual here, they're going to have to move their head a lot in order to even see the screen, which is going to be the primary thing that you'll be watching during the procedure. And so trying to emphasize a position of comfort, and a couple of do's that I would point out on this image would be that the provider has seated themselves level with the area that they're going to be working in. They should be nice and comfortable so that their hands are steady since they're going to need to work both of them, holding the ultrasound probe and the IV. That could have been either raising or lowering the patient, and this provider just decided to sit. And then making sure that you're at eye level with the machine. And here I just want to mention that there's going to be some subjectivity in terms of where you want your ultrasound machine to be positioned, but it does need to be within your line of sight so that you can watch that screen throughout the procedure. You might think this machine's on the other side of the patient's bed. It might be difficult to reach, but likely this person has already surveyed the veins and they've set it up in such a way with the gain, depth, and presets that the ultrasound machine is ready to go, and they're probably not going to have to do much more adjusting for it. But often our machines are also going to have buttons on the probe itself that will allow you to adjust depth and gain, or you could ask a buddy to come and join you and make some adjustments on the machine if needed. Now that you're set up with your ultrasound machine, you're going to want to go about finding your vein and making sure that it's a good candidate for peripheral IV access. And oftentimes we're going to be going for the upper extremity veins, though I want to mention quickly that don't forget about your lower extremity saphenous vein, because that is a very great alternative if you don't have any good candidates in the upper extremity. Just to remind us of the anatomy of the veins in the upper extremity, we have our cephalic veins that run along the lateral aspect of the arm, and then we have our basilic vein that runs along the medial aspect of the arm, and a branch off of that being the median antebrachial. All of those are usually great candidates for attempts at POCUS-guided IV placement. And then I've put just a couple of X marks here reminding us that if you can, and it's not always possible, but if possible, try to avoid the joint as much as possible. Really doesn't matter which technique you choose. If you're going at a joint in a child that's moving all the time, that IV is going to be a greater risk of being lost than one that's placed at a non-mobile, non-joint site. There are a few other factors that you're going to want to consider as you survey your veins in the upper extremity. You're going to want to find one that's somewhere between 1/2 to 1 centimeter depth from the skin surface. And that's taking into consideration that many of our catheters are about that long and a little bit longer, but not choosing one that's too deep for your catheter to actually reach. And then also choosing one that's large enough for your catheter to access. We're working with pediatric patients, and so we know their veins are going to be smaller. So you want one that's ideally greater than 0.5 centimeter in diameter so that it's easy to get into. And then you want to choose a location by surveying, I mean, just taking the probe and running it up and down that vein where you're going to find a nice straight area that doesn't have any valves that would prevent you from accessing it, or preventing that IV from being functional throughout that patient's hospitalization, ideally, if it's a short stay. When you think you found a vein, you want to confirm that it's actually a vein that you're working with. And there are a couple of maneuvers that you can apply in order to make sure that it's a vein and not an artery or some other structure. This video is showing compression, where you're going to apply just gentle downward pressure on the skin to see if those structures are collapsible. And so in this video, you can see on either side, those two vessels are collapsing, indicating that they're veins, low pressure. But right in the middle, there's an artery that doesn't collapse under pressure. And if you look very closely, as you apply pressure, you might even be able to see some of the pulsatility of that artery being displaced to the surrounding tissue. So compression is usually my first step for confirming it's a vein. And then I also like to throw on color Doppler, where I just press the color Doppler button, put the box over the vessel, and then look for pulsatile flow. Here's an example of pulsatile flow. For a vein, you would want to just see continuous flow. And I would ignore the color that you're seeing on the machine in terms of, is it blue or is it red? Because for ultrasound, that doesn't relate to whether it's a vein or an artery. That's just telling you the direction of flow in that vessel with regard to where your probe is currently positioned on the patient. So the blue color here means that the flow right now is away from my probe. And then if it were red and I adjusted my probe orientation some, that would mean that the flow is going towards my probe. So for color Doppler, you're just looking at pulsatility. The last thing I would mention is that veins, arteries, and nerves all like to run together in a neurovascular bundle. And so we're making sure we're not going into an artery with those first two steps. And then you're also just going to want to survey to see if there are any surrounding nerves that you ideally would not want to hit either. Nerves are going to be hyperechoic compared to the anechoic blood vessels. And they often look like this kind of honeycomb appearance where there's bright white lines going through it with some hypoechoic darker structures throughout. So if you see one of those, we're going to try to steer clear of that. Let's jump into the different approaches that we have available in order to do POCUS guided IV placement. The first one I'm going to talk about is this long axis view, and that's how I'm going to refer to it. It could be long axis, in plane, longitudinal view. Those are all going to be the same way of referring to the same approach, but it's represented in the top part of this figure here, where the linear probe is going to be oriented in length or long view or long axis to the underlying vessel, so that it creates this image on your ultrasound device where you have that nice pretty long axis view of that anechoic vessel. And the beauty of this view is that you're going to be able to visualize the entire length of the needle throughout the procedure. And that's in theory. And I say in theory specifically because, at least for me, it's extremely challenging to keep this view the whole time. It's so easy to slip, which is one of the cons of the long axis view, to where you actually lose the sight of this vessel. And then the other con I would mention is that if you start off in the long axis view, you haven't had really any opportunity to see, is there an artery or a nerve surrounding that particular vein that you need to miss. The pros, of course, are going to be that you see the entire length of the needle throughout the procedure and that you can follow that needle and make sure that it doesn't go through the backside of your blood vessel. But in pediatrics, I haven't found a kid yet, unless they're sedated or anesthetized, that isn't moving whenever they're having their IV placed. And so even in a sedated, anesthetized patient with just kind of the natural shake and movement of my hand, I find it challenging to hold this view, but in a moving child, it's even more challenging. So I would say more commonly, we're going to be going for this short axis view, where we're actually holding that linear probe perpendicular to the underlying vessel and just getting this cross-sectional view of the underlying vein, which means that we're also getting a cross-sectional view of our needle and not seeing the full length at any given time, but trying to keep our focus and eye on the tip of that needle, which is the bright white spot here, to make sure that we're never going through the backside of the vein. The cons, of course, are that you can easily lose that needle if you're not keeping an eye on the tip, and we'll talk about how to do that in some upcoming slides. But the pros are going to be that you can survey the surrounding structures and make sure that you're not going towards an artery or a nerve, and it's much more forgiving of slippage. I'm going to briefly talk about the long axis view since it's not as commonly used for pediatric patients, at least in my experience. For the long axis view, again, your linear probe is oriented lengthwise or in the long axis of the underlying vein, but this hand here with the ultrasound probe is going to remain still the entire time. So you just find the location that you want to see, you keep this hand still, and then you're going to orient your needle at a 30 to 45 degree angle, and this is going to be the only hand that moves throughout the procedure. And I have a little cartoon here to try to demonstrate what this looks like in practice. The black line's just representing the skin surface. You have your linear probe that's oriented lengthwise to the underlying vessel. And then this is the ultrasound image that we would see as our needle comes into view here. And it looks like it would be very nice. You see the needle go in. You wouldn't actually be able to see that part in real life, but you would see this on the image where the needle's coming under your ultrasound probe and the entire length is visualized as it goes into the vessel. In real life, this is what it would look like. And I just want to mention quickly here that this looks to be an adult patient with large vessels that's sedated, not moving. And even in this patient that isn't moving, you can see just the natural kind of movements of our hands as we're doing the procedure cause this vein to come in and out of view. And then they get it stable, and then it looks perfect and easy as the needle full length is visualized coming into the vein here. And then you can see as they go ahead and extend that catheter the remainder of the way in, and they're able to confirm that the catheter is in the vessel and did not go through the posterior wall of that vessel. So again, I'll just emphasize it looks like an amazing approach, but it's extremely challenging in real life. To move on to the short axis view, which is what we'll be practicing more most likely, the challenging part here is that rather than just one hand moving and your probe hand staying in the same place, you're going to have to maneuver both hands and move the probe as you're moving your needle. And I'll have a couple of slides coming up that will explain that better than how I can say it in words. You're going to use the same needle angle, 30 to 45 degrees, but just knowing that as you walk this needle down into the underlying vein, you're going to have to keep an eye on that needle angle and see if you need to kind of drop the tail end of your needle and catheter so that you don't go through that posterior side of the vessel. This is what it looks like again in a cartoon version. Kind of ignore this white dot right now because we don't have any needle in view for there to be a white dot. But this is what it would look like once your needle comes into view. All you're going to see is that bright white dot of the needle tip. And then I'm about to push click and it's going to show it all moving at once, which is not exactly how it's done in real life, but the following slide is going to show you more realistically what it's going to look like. This is just to demonstrate that you're going to follow that white dot all the way down until you get into the vessel and confirming that you did not go through the posterior side of that blood vessel, the vein. I think this video is a little bit more realistic what it looks like in real life. We have down here again under the white line is going to be, this is the skin. We have the long axis view of our vein. And then up here on the right hand side is going to be what you'll see on the ultrasound machine in short axis, transducer and needle right here. And there's this walking or shimmy, shuffle procedure where the probe advances, you lose the tip, then the needle advances until you get your tip. And you're going to do that all the way down until you enter the blood vessel and confirm that you're in the right location. The one pitfall of the short axis compared to the long axis, again, I've tried to mention a few times that we're going to be walking that needle down into the blood vessel, but if you don't follow the needle with your ultrasound machine, then it's going to be very easy to lose it and to end up posterior to the blood vessel, and then that vessel becomes a place that you're not able to access. So if you were to advance your needle without following it with your probe, then you're going to see as you advance forward that your needle actually went through the backside of that vessel. And so that shimmy, I don't know a better word, that walking down of the needle, is just crucially important in the short axis. And I think it's something as you get your hands on the probe, it becomes a little bit more easier to understand what that feels like. This is what it looks like in real time. You can see the linear probe oriented perpendicular to the underlying vein, which is giving us this cross-sectional view. And the bright white spot over here as it passes through the tissue and the fascial planes is our tip of our needle. And you can see now that it's entered into the blood vessel. We got a flash of blood back here in real time. And then you would just continue to walk that needle and that catheter in, watching the whole time if you continue in the short axis to make sure that you never go through that posterior wall. If you, we understand that the short axis is probably going to be what we have to use most commonly in pediatrics, but if you like the long axis in the sense of being able to confirm that you're in the correct position and not going through the backside of the vessel, then the two-axis view may be something that you would like to consider. And this is going to be done on a phantom. And so everything is going to look crisp and clean. You're going to see a bright white needle. So it's not exactly like real life, but we start off in the short axis, following that bright white spot of our needle tip all the way down into the vein until we get it there, roughly right in the center of the veins where you'd like to end up. And then you'll stop and you'll orient your probe parallel or in the long axis. And now we can see the full length of our needle as it passes through the overlying tissue down into the vessel. And this individual is then going to continue to advance the needle and the catheter, visualizing it the entire time. And so they use the short axis to get into the vessel and to make sure they weren't hitting any surrounding structures. And then once they're in the vein, they switched to the long axis. And so this could be a good option if you want to do a combination of the two. That kind of completes going through the short axis and the long axis. In terms of complications, these are going to be essentially the same as what you would encounter if you were doing the palpation kind of standard technique of IV placement. But the good thing about ultrasound is you can confirm or troubleshoot what you think is going on by seeing and visualizing it on the ultrasound itself. So for an infiltration or an extravasation, your ultrasound is going to show you what looks like fluid in between the tissue planes, sort of like a cellulitis would show up as. And then for a thrombophlebitis, you might be able to visualize a little clot in the blood vessel. For misplacement, if the nurses are having a hard time pushing anything through the PIV or drawing from it, you could take the ultrasound and see if you've gone through the posterior wall of the blood vessel or if the catheter is maybe eroded through the posterior wall. So this is one that's now not in the blood vessel, but is sitting in the tissue and would not be functional. And then unfortunately, I can't show you a great picture of nerve injury, but I was just going to do one final reminder here of we want to kind of watch for those neurovascular bundles where our nerve, which is the hyperechoic honeycomb type of structure, can sit very closely to an artery and a vein, which will look very similar, and we'd have to use compression and color Doppler to make sure that we're dealing with a vein. But ideally, going for a vein that's not in that neurovascular bundle to where you don't have to worry as much about hitting something that you didn't intend to get. And then finally, a hematoma could develop, and that's just going to look like blood that's extravasated into the surrounding tissue around the vein. And so it appears hyperechoic compared to the anechoic vessel that it's surrounding. And so that's what I had for a POCUS guided PIV placement. I'd love to take any questions that may have come up during the presentation. And then if you don't mind, just taking the opportunity to scan the QR code here and giving us some feedback. I've also included some references that I used to build this presentation out. Those are going to be in Padlet, and I can upload this presentation to that too so that it's accessible in the future as well.
Thanks so much. Every time I watch you present, I'm like, I need to step up my PowerPoint game. So really grateful for the excellent slides. And yeah, if there's any questions, feel free to just unmute yourself and ask, or you can type them into the chat box.
Thank you. This is really helpful. I feel like I've practiced so many times on the Blue Phantom and it feels so easy on that. And then I never get it in patients. And I'm just wondering if that's a common experience and just gets better with time.
Yeah, I would say 100%. Dr. Rankin, feel free to speak up. That same experience for me. I felt like the Phantom was super easy to learn on. Like I can just follow it down. It's bright, crisp, clear images, and then just real life tissue is not the same. Patients moving, it's never going to be the same as the Phantom. So I think it's just time.
Really right.
Yeah, most research shows that it takes anywhere from about 10 to 20 successful attempts to maintain competency. So I would say like around 15 is kind of the sweet spot. That's what we when we train our nurses in the EC to use ultrasound for IVs, we have them complete 15 successfully before they're kind of checked off. So yeah, definitely give yourself grace. It is not an easy skill to learn, and it takes multiple attempts before you start to feel good about it.
Okay. That makes me feel better. I'll keep
Don't give
trying.
up.
It seems intuitive, but I mean, would you generally suggest starting with teenagers, like the
Yes,
bigger ones before trying the babies?
yes,
I would assume, yeah.
for
And then
sure.
the
And
other quick question. Oh, sorry.
also, I don't know if like your crew is cool with it, but you can also practice on each other. We do that quite a bit, if you're not squeamish. But yes, I would definitely start with teenagers with big, and they're still, and they have big juicy vessels.
Yeah,
When
one way
you're,
to sorry, go ahead.
oh, I was just gonna ask, when you puncture the vein, do you typically actually lower the angle a little bit at that point to try to insert the catheter, or just keep with the same approach?
I usually just walk it down kind of at a similar angle until I get into the vessel, and then I kind of compare if I need to drop it at that point as I advance it within the vessel itself. Dr. Rankin, is that kind of how you?
Yeah, I think generally if you just always try to keep your needle tip in the very center of the vessel, you'll kind of start to realize what adjustments you need to make to do that. So every time you kind of readjust and scoot your probe forward and you're chasing it with your needle tip, you're going to end up in a slightly different spot in the vessel. So in between each little scoot, just kind of make sure you're right back in the middle of that vessel and then proceed.
I'm gonna
I've
say
also,
one way to get some reps too is to talk to the nurses if you're doing hospital medicine, to talk to the nurses um, at the on whatever your unit is, and ask which patients are due for having their IVs swapped, because generally they're, it's protocol driven, but if it's an older patient, sometimes they'll let you take a crack at it with the ultrasound machine. And some of the newer machines also have features that enhance the appearance of the needle, make it brighter and easier to see, which is helpful too. If you're doing just like a handheld probe, it's a little bit more challenging.
we also have a vascular access team at our hospital. That's usually their hours are like 11 a.m. to 11 p.m. And so anytime I see them come on the floor, I'll just try to grab them and be like, hey, can I go with you on this one? And it's helped.
Yeah, they're
Kind
a
of.
really good resource.
Mhm.
I came in late, so I'm sorry if you answered this already, but what size needle are you using?
I've had anywhere between 22, 24 at gauge, I feel like is the most common. Dr. Rankin, is that? Can
Yeah,
you go?
so I would say if the patient is less than 1, you're definitely going to use a 24. And then in between 1 and 2, it can kind of be variable. Um, and then like your school age kids, it's probably going to usually be a 22. And then as you get up to like past 10, you're probably going to start using a 20.
Okay, because the
Sure.
20 is the only one that we have available here in like a longer size. But
As long as your catheters are long enough, like I never go for anything deeper than a centimeter.
okay.
I think the sweet spot is kind of like half a centimeter. The really, really superficial ones are also kind of difficult, I think. So usually a general catheter length will get you there to like a half a centimeter deep vessel. So you could try those with your 22s and 24s.
Okay, thank you.
There was a
Yes.
question in the chat about the sterile glove hack and
Yeah.
whether you use a rubber band.
Yeah, I think that was actually an image that I took from Andrea, but I haven't personally used the sterile gloves myself. I think in a pinch, I would probably try to hold it so that I'm not looking for a rubber band. But if I had one handy, that's probably what I would try to do so that I'm not, making my hand cramp up as I'm trying to not only hold the device, anchor it, and hold the glove on at the same time.
Yeah, it gets kind of bulky. There's a lot of new kind of fancy probe covers that are awesome, but they're really expensive. Like $5 a cover, so like nobody's gonna buy that. Um, and like Cody said, it's a clean procedure. So we were using Tegaderms, but they were completely trashing our probes. So honestly, if you just clean the don't tell anyone I said this, but if you just clean the probe really well before you use it, clean the patient, and then clean it when you're done, it should be fine. But I do find that the glove works, and you do have to put a layer of gel on top of the probe and then put the glove on and then use more gel. You can't just put you can't get like a naked probe and just put a glove on it. But it just does get really, really bulky, especially in the little kids where you're already using like maybe a hockey puck or a tiny probe anyways. So you can try it. I find it difficult.
In a pinch, I've used the barf bags as a probe cover. So
Yeah,
but you need a rubber band for that and quite a bit of
yeah.
gel at
Rubber
the
band
bottom of
helps a
that
lot.
thing.
Yeah.
Yeah.
And get
And
really
then the really long sleeves, has anybody ever looked like a total moron trying to like figure out where to put the sleeve? And it's like, who constructed this? But you really got to play with those and get used to them. And you also need to put gel in the tip of those as well.
You might be able to at like some of the conferences coming up if you're attending any. There's always ultrasound booths, and sometimes they'll give away stuff like probe covers and that sort of thing. So it's a good time. Summer conference season is a good time to stock up on some of those supplies.
Yeah, I have my own personal stash in my work bag.
Cool. Well, this has been great. I hope everybody takes the time to scan the QR code and give feedback. And I'll go ahead, I'll send a link to in like a follow-up email with some of the upcoming stuff so that you can give feedback as well. And this will be recorded, or it was recorded. I'll put it on the YouTube channel. We'll send out a link for that. So
awesome.
appreciate
Yeah.
your time.
Thank you, Scott. Appreciate everybody.
Yeah. Yeah.
Thank
Bye.
you.